Good morning and welcome to our Advanced Lung Disease Symposium at UCLA. It's so great to see so many people without masks at times in the same room. And we have over 200 registrants for this symposium. Half of them are here, half of them are virtual. And for those who are listening to this virtually, we want you to know of the option to ask questions or chat virtually. And for those of you who are here, we will have a session at the end of each group of discussions where you are given the opportunity to ask questions. As many of you know, this past 2 years has been quite a challenge for all of us in the healthcare, and I want to shout out to all the staff, especially our nursing staff, our physicians, and all the allied health who have made it possible to persevere and take care of so many lives over the past several years and save lives. As some of you may know, transplantation has been a very important part of UCLA healthcare since its inception. Some of the first kidney transplant on the West Coast, first heart and lung transplants on the West Coast were done at this institution. In fact, in the past 5 to 10 years, UCLA has always ranked among the top 3 medical centers in terms of volume of solid organ transplants. In 2020, UCLA was the largest solid organ transplant program in the country. And last year we were among the top 2. As such, all the solid organs are well represented. We've been consistently ranked in the top 2 or 1 among the kidney transplants, liver transplant, heart transplants. And obviously over the past several years, the lung transplant program has expanded with the help of many of the individuals who are presently in the room to make it among the largest programs in the country. But what we especially take pride in is the quality of care that is delivered in these in our ICUs and the post-transplant units. And we have a lineup of some very timely topics today that will bring you up to date to where the field of end-stage lung disease and lung transplantation is going. And our first speaker is Dr. David Sayam. He's the medical director of the UCLA lung transplant program. And I invite him to come up here because he has some introductory comments as well. And then we will have 2 or 3 or lectures, and then followed by a break. And then in a similar fashion, we go throughout the day. Welcome all of you. Look forward to have a interactive session, and thank you for being here.
Thanks, Albas. It's so great to see so many people here in person. I know there's many people here virtually. It's a real pleasure actually to be able to gather together for a conference like this. And I think it's kind of nice that we can do a combination of hybrid and in person. There's some people who are, I think, logging in from quite far away where it might not be practical to be here, even if it wasn't for COVID. So I think, one of the silver linings of this pandemic may be these kinds of hybrid meetings. Before we get started, I just wanted to thank some of the people that made this possible. Melissa Moore, who is manning our virtual questions and has been instrumental in making this possible. So thank you so much, Melissa. The UCLA CME office, Danny Chambers, Kimberly Norson, and Suzanne Alvarenga for, again, putting this all together and making it possible. All of the speakers who've generously sort of donated their time and effort to being here, and all of you who are attending. Obviously, this has been a stressful couple of years, and in particular for those of us who work with patients with lung disease, it has been a real challenge. And so I really appreciate everyone being here today. I'm going to give a little bit of a overview about the status of lung transplantation in this year of 2022, things that have changed, updates that we should all know about, in terms of what's going on in the field of lung transplant. These are my disclosures. None are really relevant to this talk. So I'm really going to highlight 3 subjects within the field of lung transplantation that I think are relevant in this year of 2022. There's some updated international referral and selection criteria about who should be referred for a lung transplant, who's a good candidate for a lung transplant. So I think it's worth spending some time on that update. You can't really talk about lung transplant in 2022 without mentioning COVID-19, so we'll spend a little bit of time on that. And then I think one of the things I'm most excited about is the research that is going forward in the field of immunosuppression and lung transplant, some of that being spearheaded here at UCLA. And so we'll focus a little bit on that as well. So these are the 3 things I wanted to share with you today. So let's start off with the referral and selection criteria updates. As most of you in this room know, lung transplantation as a therapy for end-stage lung disease continues to grow. Every year, year on year, there's an increase in the number of transplants done worldwide or in the US. This is international data from the ISHLT. So there's something like 4,500 lung transplants done per year worldwide. I think it's approaching 5,000 actually in the last year or 2. And about half of those, or more than half, are done in the United States. So about 2,500 a year in the US. And as of 2018, there were over 15,000 people in the United States who were alive and had had a lung transplant, which is a remarkable number when you think about it. That's not that rare compared to some of the rare diseases that you're going to hear about later today. You know, it's not common, but it's not rare. And so more and more, we are going to see people who've had lung transplants in community hospitals and settings outside of transplant centers. And so familiarity with this therapy is going to be increasingly important for every pulmonologist, for every ICU physician. Eligibility for lung transplantation has been expanding, and I think this has been the theme over the last decade or 2, that many patients who were previously considered not candidates for lung transplant can now be considered as candidates. Some of this work has been pioneered here at UCLA, specifically with respect to patients who have severe coronary artery disease, connective tissue diseases such as scleroderma, patients who are dependent on ECMO, and you'll hear about some of these topics in other talks today, as well as people who have the need for multi-organ transplantation, so other organ failures, not just heart, lung, but lung and kidney or lung and liver. These are all patients who not long ago would have been considered not eligible, and now they're transplanted routinely at centers like ours. And so I think this has been a big change over the last decade in particular. And so guidelines are always behind where clinical practice is, but there was an update to the guidelines from the ISHLT, the International Society for Heart and Lung Transplantation, released late 2021. So these are just about 4 months old. And these update are sort of international ideas about who is a good candidate for a lung transplant and who is not, and what we should be considering when we're thinking about it. So in terms of general principles, who should be considered for a lung transplant? People with end-stage lung disease, and we can define that different ways, but I think a high risk of death within 2 years is a good definition. What does high risk mean? Well, 50% risk of death within 2 years is sort of where this consensus is, although obviously that's somewhat arbitrary. And then the other component is the absence of serious medical or psychosocial conditions that are likely to impact the survival after the transplant. So someone who has a high likelihood of 5-year survival, if not for the transplant. So they don't have other life-limiting medical conditions. Those are the general principles. So obviously, these are going to be applied differently in the big disease categories that we think of. And we typically think of 4 big disease categories when it comes to lung transplantation: COPD, pulmonary fibrosis, cystic fibrosis, and pulmonary vascular disease or pulmonary hypertension. And I wanted to spend a minute going through the referral criteria for each one of these sort of big disease categories. And again, it's important to keep in mind that these are referral criteria when patients should be referred, not necessarily when they should be transplanted, which is a whole other sort of set of considerations. And let's start with COPD. So in patients with COPD, obviously we want to start with optimal medical therapy. So in those already receiving optimal medical therapy, a BODE score of around 5 or 6, plus additional risk factors. Those risk factors include frequent exacerbations, a BODE score that's increasing over time, an enlarged pulmonary artery on imaging, an FEV1 in the low 20% range. So those would be sort of the indicators of a higher risk of mortality. Unacceptable quality of life is another important consideration. It may be that for some patients with COPD, transplant may not provide a survival benefit in all cases, but sometimes there's a quality of life benefit that's worth the trade-off. It's worth having a transplant purely for quality of life, even if longevity is not extended. And another important consideration that was added to this consensus guideline that wasn't there in the past is considering referral for simultaneous transplant and lung volume reduction for a patient who's a potential candidate for both. And so considering centers like ours that are able to do simultaneous evaluations for both, and then the patient can make a decision along with the medical teams about which is the best option for them. And you'll hear more about advances in lung volume reduction later today from Dr. O. What about for interstitial lung disease patients? This makes up the bulk of lung transplants done worldwide. Interstitial lung disease is the #1 indication worldwide in the United States and certainly here at UCLA. And you'll notice that in ILD patients, there's no mention of optimal medical therapy because optimal medical therapy for ILD, unfortunately, is still sort of suboptimal, doesn't work that well. And so these referral guidelines are independent of therapy. So the guidelines state to refer patients who have either radiographic or histologic diagnosis of UIP at the time of diagnosis. That's fairly aggressive. And I think the reason for that is that these patients can deteriorate rapidly. Now, you can apply different thinking to different practice settings. Those of you practicing at UCLA, for example, have relatively easy access to a transplant program. It may be that others, there may be challenges in terms of getting into a transplant center. Referral at diagnosis may not be appropriate for every patient, but certainly a conversation at diagnosis, I think, is appropriate for everyone. And then a low threshold to refer if one of these other events happens. So an FVC less than 80%, or DLCO less than 40, declining lung function defined, as you can see here, as a drop in FVC or DLCO, any need for supplemental oxygen, whether at rest or exertion. In patients with inflammatory ILD, let's say ILD related to connective tissue disease, NSIP, or something similar, progression despite immunomodulatory therapies. And then in patients with complex cases, complex connective tissue disease like scleroderma with extrapulmonary manifestations, or people with familial interstitial lung disease, in particular telomeropathies, that complexity may actually make the transplant evaluation take longer and require more steps. And so early referral is recommended in those cases as well, because the evaluation may take longer. What about cystic fibrosis? These guidelines were significantly updated in collaboration with the Cystic Fibrosis Foundation over the last couple of years. It used to be that FEV1 less than 30% is sort of the gold standard everyone has in mind. And this is really expanded as well to encourage earlier referral. So FEV1 less than 40%, along with one of these additional risk factors you see listed, which include either hypoxemic or hypercarbic respiratory failure, low 6-minute walk distance, worsening nutrition, recurrent exacerbations, hemoptysis or pneumothorax. And with all of these conditions, secondary pulmonary arterial hypertension is always an ominous sign and should always prompt referral for lung transplant consideration. And then even FEV1 as high as, let's say, 49%, so less than 50% with rapidly worsening disease may be an indication to refer as well. And then anytime there's an exacerbation that requires positive pressure ventilation. And we can see a theme here in these updated referral guidelines that they are progressively encouraging earlier and earlier referral, because one of the big problems we have in lung transplant medicine is late referrals, which we'll get to in a moment. Finally, in patients with pulmonary hypertension, I know that Dr. Sagar is going to go through this later today, so I won't spend too much time on it, but basically patients with high risk, depending on the risk score you want to use, the SCERS score or the REVEAL score, significant RV dysfunction, anyone parenteral prostanoids, so IV or subcutaneous prostanoids, people with progressive disease or hospitalization for RV failure, certain high-risk variants that respond poorly to treatment, PVOD, PCH spectrum patients, patients who have scleroderma, because we know again that those are complex patients where evaluation may be prolonged, and then anyone who's developed secondary liver or kidney dysfunction, again, an ominous sign in these patients. So the theme I want to leave you with going through these referral guidelines is that early referral is essential. For a moment, I want to talk about contraindications to lung transplant. This is always very center specific. So there is no universally accepted list of contraindications that apply across the board internationally at every center. But these are sort of the consensus ones listed in the international document that I think are relatively non-controversial, that everyone would agree with. And you can see this list is actually not very long. So obviously patients need to want to transplant. High-risk malignancy is a problem, although exactly how we define high-risk malignancy may vary center to center. We basically think of it as, going back to that first principle, something that's going to limit 5-year survival. Other organ failures, unless there's a multi-organ candidacy, refractory infection. So, what constitutes a refractory infection? Not long ago, hepatitis C was a refractory infection. That's very much not the case anymore. HIV used to be considered a refractory infection, not the case anymore. So the list of what is a refractory infection is shrinking. And then psychosocial barriers, including inability to adhere to the medical regimen, substance abuse, and then poor functional status, so non-ambulatory status, which has been a major problem for our COVID patients, and highlights the importance of physical therapy for people who have respiratory failure due to COVID and may be candidates for transplant down the road. Sometimes it's not possible, but whenever it is possible, we always strongly encourage as much PT as early as possible in these COVID patients. And despite the guidelines over time increasingly emphasizing the importance of early transplantation, we can see that in 2003, down at the bottom here, comments about late referral and the problems associated with late referral in terms of impacting transplant opportunity and survival after transplant. And more recently, 5-6 years ago, again, commentaries about late referral, in this case specifically related to cystic fibrosis. But I think late referral is probably the biggest problem we see in terms of transplant referrals that we receive. And one of the main reasons that people aren't able to get transplants, not necessarily because they have inherent contraindications, but because they're referred so late that they miss their window. So if there's one takeaway from my talk today that I want you to leave with, it's to refer early. And I would say that's particularly true of our ILD patients, where they can have such unpredictable and rapidly progressive courses. So I want to segue from that to talking about COVID-19 and some of the challenges associated with transplantation for these patients. In many ways, the timing of lung transplant for COVID-19 is reversed from what we usually think about. So if we think about a typical progressive lung disease like the ones we just went through, someone is diagnosed with COPD or IPF or whatever the disease is, and then we put them on medical therapy, and unfortunately, some of those patients get worse despite therapy. And then ideally, they're being referred to us, right, sort of at the end of this green area going into the yellow. And that's what those referral criteria are sort of pointing out. And so we get referrals in this window. Patients get evaluated for transplant. Hopefully they get transplanted and they do well. Patients who are referred here at this margin between yellow and red, it's much more of a challenge, and there's a risk that they're going to miss their opportunity. With COVID, this is exactly reversed, where when someone is first admitted to an ICU or first put on a ventilator or first put on ECMO for COVID, they're too sick to consider transplant. They have an active infection. We don't know what their prognosis is, and they can't be transplanted at that time. And so what we're trying to do is actually get that patient into a transplant window. And some of this is medical therapy. Some of this is supportive care like ventilators and ECMO. And I would argue that a big component of this is as much physical therapy as we're able to provide to these patients to prevent them from developing the ICU myopathy, from developing the malnutrition, from developing the skin breakdown, all of these things that can then impact their transplant candidacy. And this is a difficult task, as we all know, those of us who've taken care of critically ill COVID patients over the last 2 years. This is not easy. But this is really the only way to get patients into this transplant window where we can consider them for transplant and potentially be able to offer them a life-saving lung transplant. One of the additional challenges here is that we have all seen patients, I think, with COVID where we thought this person's never going to get better, and they do. And so the uncertainty of outcome once patients are sort of a little bit better, not much time has passed, is an additional challenge. And so trying to figure out who would benefit from a transplant and who is just going to get better on their own has been a big challenge without easy answers right now. So to highlight that, I want to show you 2 cases that were in our ICU at almost the same time. One was a 29-year-old woman who'd been on ECMO for a month, and this was her X-ray at the time on ECMO for a month. The other is a 55-year-old man, also on ECMO for a month. You can see they both have tracheostomies. This patient has multiple pleural catheters, chest tubes in place. I think I see three, 1, 2, 3. And the lungs obviously look terrible in both of these patients. These are CTs at about the same time, so this is about a month in. And you can see they both look terrible to me. And looking at both of these images, I have a hard time saying this person needs a transplant, that person doesn't. And this is, again, right about 4 weeks on ECMO. And I can tell you the outcome was that a month after that, this patient got better, got decannulated, went home. I had a video visit with her about a month ago. She's completely off oxygen, and she can do what I consider the ultimate stress test, which is go to Costco and push the cart around, and can accomplish that with her kids. This patient was unable to wean from ECMO and ultimately required a lung transplant and is doing very well. But this case, I think, points out to me the critical importance of, taking a close look and deciding whether or not a transplant makes sense for an individual patient. And I think time and CT imaging are critical factors here. And part of the reason why that transplant window, I don't think really opens for the first month or so. So this is a consensus approach that we take at UCLA, and that's basically the approach taken around the country. And there's not formal criteria for this, but there's been many editorials and many people have shared their experiences, many centers have shared their experiences. This is pretty much the consensus around the country and around the world, is that there should be evidence of irreversible lung disease. This, as I just showed you, can be challenging. So how do we define it? Probably some combination of time passing. We think anything less than about 4 to 6 weeks is probably too soon to transplant, although not too soon to refer. And then CT evidence that there's really irreversible lung damage. We want to see clearance of infection, obviously. Functional status, this is probably the #1 thing. We need people to be able to stand up or to bear weight, hopefully take a few steps, but at least be able to stand. Ability to give informed consent is critical. And then otherwise an appropriate lung transplant candidate by all the other criteria we talked about. In the last few minutes here, I want to take some time to talk about exciting new developments when it comes to approaches to immune suppression and lung transplant. So this is international registry data from the ISHLT. It's a couple of years old, but hasn't changed much. And you can see that between sort of what we consider the first era of lung transplantation in the early 1990s and a second era in the early 2000s, there was a significant improvement in survival. Most of this was driven by improvements in surgical technique pioneered by surgeons like Dr. Ardahali and colleagues, where the 1-year survival went up very significantly. And most of this, we think, is due to improvements in surgical technique. So patients did better early. But if you look at the slopes of these curves afterwards, they're relatively unchanged. And so even in the most recent era, let's say the 2010s, there's been further improvement, but it hasn't been as rapid as we would like. And long-term survival remains limited. Median survival remains in this sort of 6-year range. Conditional survival for those who survive the first year is better, but still not as good as we would like, and still not as good as most other solid organ transplants. So why is this? What limits post-transplant survival after lung transplant? Well, it is what we used to call chronic rejection, what we now call chronic lung allograft dysfunction, or CLAD. That is the leading cause of death. These are data from the United States, from SRTR, and you can see that the two top causes of death here over time, again, once we get out from the first year, are in purple here, graft failure, and in orange, respiratory. And those are both basically people who've had failure of their lung allografts, and most of this is going to be CLAD. Other causes of death, infection is probably the next leading cause of death, and then over time, malignancy comes up and becomes a leading cause of death as well. So CLAD is the #1 cause of death, and then infection and cancer are #2 and #3 over time. Immune suppression has not really evolved over time. Immune suppression regimens today really don't look very different than they did 30 years ago. So this is a timeline actually from a liver transplant journal. I used it because it's a nice timeline. And it shows what our current regimen is for lung transplant, for really all solid organ transplant. Corticosteroids, obviously, antimetabolites like azathioprine, which was introduced in the 1960s, or mycophenolate, which was introduced in the 1990s, and then a calcineurin inhibitor, cyclosporin, obviously introduced in the early 1980s and revolutionized solid organ transplantation, and then tacrolimus introduced in the 1990s. And that's it. It hasn't really changed. We use the same regimen today as we would have used in 1990. There have been some additional agents introduced. So sirolimus we use in some cases, although it's not typically used as maintenance immune suppression from the beginning of immediate post-transplant period. Some induction agents have been introduced, antithymocyte globulin, IL-25 receptor antibodies, but these are relatively minor advances, and they're also over 20 years old. So we desperately need better immune suppression regimens. CLAD remains the leading cause of death, and actually complications from immune suppression are the next leading causes of death. So infection and malignancy are directly related to the immune suppression that we use, and are the other two big problems. So better strategies are really desperately needed in this field. So one promising therapeutic option are drugs called JAK inhibitors. These inhibit T cell signaling, as well as having some other effects on the immune system. And these are images from Dr. John Belperio's lab using a mouse orthotopic lung transplant model. Believe it or not, people can do lung transplants in mice. People in John's lab are really expert at doing this. And you can see a mouse who's had an allo lung transplant, so HLA mismatched lung transplant, or MHC mismatched lung transplant, and not given immune suppression, developed severe rejection. You really can't see any lung architecture here. This doesn't look like lung. Whereas a mouse that's treated with a JAK inhibitor, specifically itacitinib, you can recognize the normal lung architecture we're all familiar with these delicate alveolar septal walls that looks very, very normal. And this work really came after years of effort by Dr. Belperio's lab, as well as others, to elucidate the underlying mechanisms that lead to rejection in this model. And so this really laid the groundwork for what I think is going to be a groundbreaking trial, an NIH-funded study called INHIBIT-CLAD. This is going to be a trial of itacitinib specifically to prevent CLAD. It's really based on preclinical work that was pioneered here at UCLA. This is going to enroll something like 350 lung transplant recipients across 6 centers throughout North America. And this is really unprecedented. You know, for people in other fields, for cardiologists, to study with 350 patients sounds tiny. But for lung transplant, this is huge. This is a gigantic study of immune suppression. It's going to be co-led by our center and Duke, and John Belperio and Sam White, who you hear from later today, are going to be directing this study at UCLA. And essentially what this is going to do is enroll patients with high-risk transbronchial biopsy findings. So a patient who we think is at elevated risk of developing CLAD, they'll be randomized either to standard immune suppression or to standard immune suppression plus itacitinib for a follow-up period of 2 to 4 years, with a primary outcome of development of CLAD. And hopefully we're going to see improvements. And hopefully we're going to learn more about future strategies and other approaches we can take down the road. Not only is there going to be one study, but there's actually a second NIH-funded study that we're participating in. This is a study of an IL6 inhibitor, whose name I can't pronounce, so I'm not going to try. But it's an antibody that inhibits IL6. This is going to be at 15 sites across North America. In this study, patients are going to be started on this drug versus not this drug, so placebo plus standard immune suppression at the time of transplant, continued for 6 months. With similar outcomes, 3 years of follow-up, and again, an outcome really focused on the development of CLAD. And Sam White is also going to be the PI of this study at UCLA. So I think this is probably the most exciting thing in lung transplant, is that I think we are on the verge of having new immune suppression, better immune suppression, and studies like these. I'm excited to be able to offer to our patients who are going to get transplanted here in the next few years, to give them an opportunity to participate in something like this that maybe will benefit them, and I think will certainly benefit future patients down the road. So to summarize, what do you need to know about lung transplant in 2022? Well, more patients than ever are candidates for lung transplant, but early referral remains essential. So as I said before, if there's one message you take away today from my talk, I want it to be that early referral is really critical to getting the best outcomes for your patients. Transplant for COVID-19 is a unique challenge, both because of the course of disease is unpredictable and because many patients become severely deconditioned by the time that that their lungs are in a situation where we think transplant makes sense. And that CLAD remains the biggest challenge in lung transplant, and that better immune suppression, I think, is badly needed. And I really am very hopeful that it's coming soon. So with that, I'm going to thank you all for being here and for your attention. And I want to introduce Dr. Albas Ahmed, who's our surgical director for both the lung, heart-lung, and heart transplant programs at UCLA. He's really been a pioneer in some of the advances we talked about in terms of expanding who's eligible to get a lung transplant. And I'm excited to hear his talk today.
Thank you, David. Good morning again. My task is to give you an overview of some of the surgical advances in the field of lung transplantation. In addition to my topics, I've taken the liberty of adding two other, which is talking a few minutes about bridging to lung transplantation and some specific data about the current status of the lung transplant program at UCLA. No financial disclosure. I was the designer of a catheter that's used for ECMO and was recently approved by the FDA. As you know, I think this is the wrong set of slides, but we'll go ahead and move forward. The first lung transplant was performed in 1968 in Jackson, Mississippi. And the patient was someone who had lung cancer. The patient survived for about 18 days and passed away from renal failure and infection. And it's interesting that, thank you, it's a condition that we would never transplant somebody these days, but that indeed was the first patient. The contemporary era of lung transplantation was started in the early 1980s by the experience from the Washington group. And they were the pioneers who actually pushed the envelope and offered a life-saving therapy in patients with interstitial lung disease. And for the first 30 or some years of lung transplantation, allocation of donor organ was very simple. First come, first served basis. It was a line. So we were transplanting all the COPD patients with all the pros and cons of it. Things changed in 2005, about 16, 17 years ago. And a new allocation policy came about, which allocated organs, not to the ones who could survive the waiting list, but to people who needed it the most. And as such, fibrotic lung disease was the most common indication for lung transplantation. And we began seeing more and more patients with other conditions. These were older patients who had other comorbidities. And among the most common conditions with end-stage lung disease is heart disease. So we began seeing a large number of patients who had coronary diseases or valvular heart diseases and so on and so forth. Like many centers, we initially said, no, you can only have isolated lung disease. But after a while, we felt that we need to push the envelope and open the potential for some of these patients getting lung transplantation. Many of these patients had other heart conditions such as atrial arrhythmias, atrial fibrillation, even aortic aneurysms, in addition to commonly known coronary artery disease and valvular heart diseases. There were several studies that have looked at the experience of concomitant heart surgery in addition to lung transplantation. We know that these patients are high risk just by the nature of their condition. We know that it adds complexity to the procedure because they have to be anticoagulated, some of them. And they require a special staffing technique. In other words, it's very difficult to do endoscopic vein harvest for bypass surgery at 3 a.m. and have staff 24/7 to be able to do this sort of thing. Several groups have looked at the experiences with concomitant cardiac surgery and lung transplantation. You can see the list of these. And there is an additional study that was published in 2018. But the largest study actually came from our group, the UCLA, and we looked at 620 consecutive lung transplant patients, of which about a fifth of them had concomitant cardiac surgery. In other words, 1 out of 5 had some sort of a heart procedure in addition. And the reason for that was that we became the referral center. We had so many patients coming from Pacific Northwest as well as Mid-America that were being turned down at other centers, and because of their heart condition that were referred to UCLA. And you can see the percentage of the patients who actually had concomitant cardiac procedures. And this is a busy slide, but I want to focus on the first 2 columns, which is the control group, and compare that to the concomitant cardiac surgery. These were matched groups. And you can see that when you look at and the third column is the p-value, which is probably easier to follow. And if you look at all that, the third column, you see that there was no difference in terms of early postoperative management and outcomes between the patients who underwent isolated lung transplant versus the ones who had some sort of a heart procedures as well. That included the duration of mechanical ventilation, re-exploration, ECMO, PGD grade, ICU stay, 30-day stay, and so on. This is only at 30 days or during the early hospital course. But when we look at the longer-term data, up to 5 years post-transplantation, again, we did not notice that the patients who have cardiac disease are more likely to die of their heart condition unless or if the heart condition has been addressed. And this is a proof of the fact that if you address the heart condition along with lung transplantation, these patients have a chance of living at least a minimum of 5 years. And I think this is one of the convincing data for our center in terms of continuing to offer lung transplantation to patients who have cardiac conditions. We feel that lung transplantation and concomitant cardiac procedures can be performed safely with acceptable 5-year survival. And we think that this is the only way that we can expand safely the option of lung transplantation to some of these patients who are in need of a life-saving procedure. We continue to offer concomitant cardiac procedures. We've done bypass surgeries in patients over the age of even 70 who have undergone lung transplantation with acceptable outcome with increasing experience here. The other topic that I was tasked to discuss is multi-organ transplantation, which is heart-lung or lung-kidney and or lung-liver transplantation. With heart-lung, as you can guess, the indication is basically uncorrectable heart condition. We try to do as much as we can with the heart to repair the heart condition and then do the lung transplant. But there are certain conditions where the heart is not correctable. When it comes to lung-kidney, it's the patients who have systemic diseases or have been on calcineurin inhibitors for a long time because of their prior lung transplant with GFR of less than 45. And when it comes to liver disease, it could be either cystic fibrosis or unrelated liver conditions. When you look through the literature, there is very limited information on patients who have had multi-organ transplants with lung. And the reason for that is that the numbers are very small. This is basically on the total US experience based on SRTR data that shows that the number of patients who have undergone, let's say, heart-lung has never exceeded 40 in the past at least decade. We talk about it a lot, but the numbers is quite small. And the number of patients who have undergone lung-kidney has not been more than 10 or 15 cumulative experience. However, we have been one of the first centers who have been offering these combined organs to patients with end-stage lung diseases. This is another busy slide, but I just want to point out the fact that what the median age and interquartile range is for patients undergoing multi-organ transplants. For heart-lungs, it's 44, and the oldest, at least interquartile range, is about 52 or so. And then if you look down in terms of the, most of them have undergone double lung transplants. It tells you about a little bit about the demographics of some of these patients. But keep in mind that the total experience with these combined organs is quite limited. When we look at the survival for heart lungs, you can see that there is a large drop in the perioperative period. And it's all related to the early mortality relating to the surgical complications. We have done about a dozen heart-lung transplants over the past 10 to 15 years. And all of our patients at UCLA have survived up to 1 year and have actually survived the surgery and survived to 1 year, which is not truly reflective of the national data. When we look at the lung liver, again, the numbers are quite limited. You can see that the survival is very similar in the long term with compared to isolated lungs, but there's a drop-off in the perioperative period in the early surgical complications. And when we look at the lung kidney, you can see again that there is an early drop-off, but the curve, the slope remains unchanged, suggesting that most of the complications and mortalities related to multi-organ transplant occurs in the first few weeks after surgery. If we can get them through, most of these patients do well. The take-home message is that multi-organ transplant is available. It is being offered at UCLA, given the depth of experience in kidney transplant and liver transplant and heart transplant at UCLA. And we will continue to look at some of these patients who may benefit from multi-organ transplants. I want to switch gears and talk a little bit about bridging candidates to lung transplantation. You're going to have a thorough discussion by Dr. Gudzenko in just a few minutes, but I wanted to bring a surgical perspective to this because I think it's very important to think about it both from a medical as well as the surgical end. 10 years or so ago with end-stage lung disease, things were a little bit easy. Anybody who could not breathe or they had to be intubated and sometimes sedated so that they can be getting adequate oxygenation through mechanical ventilation. And we knew what the complications with mechanical ventilations were. About 10 years or so ago, we began offering ECMO as a bridge to lung transplantations. The advantages of ECMO is that the patients are awake. Some of them are ambulating. They have effective gas exchange. We think that they may have decreased adverse event. And as you can see from the right lower corner, there has been abundance of experiences that have been published in ECMO as a bridge to lung transplantation. We had one of the largest experiences in veno-arterial ECMO. Most of these reports are VV ECMO, whereas our experience was predominantly veno-arterial ECMO. So we looked at our experience, which was about 58 patients that were bridged to ECMO, 27 VV, and 31 veno-arterial ECMO. And 82% of the patients that were placed on ECMO with the intention to treat were actually bridged to lung transplantation. The average number across the country is about 50, 60%, because a lot of these patients don't do well during the bridge phase of ECMO. And I think one of the most important aspects of our program is that virtually all the patients were awake and greater than 90% of them were ambulatory. And I think the key element in the success of our program was the fact that it took a multidisciplinary team, as you can see in this video, of about 7 or 8 people trying to move and help one patient walk every day, maybe more than once a day. And just imagine if you have a 12-bed ICU, of which, actually 24-bed ICU, of which about 8 to 10 of them are ECMO patients. And if you want to have them walk every single one of them at least once a day, you can imagine what it takes to be able to get the team moving and getting each of these patients mobilized. And I think the tribute and accolade should go to our ICU nursing staff the nurse practitioner, the physical therapist, the occupational therapist, some of the people who are here who've made this possible. We found that in this cohort of patients, which is the largest VA ECMO cohort that has been reported, published, is that the incidence of PGD3, which is that severe form of the graft dysfunction after lung transplantation, was 2%. With the early survival to discharge was 98%, with a 3-year survival, which was very similar to the non-bridged cohort. Now, one can look at this and say that you guys are too selective. That may be true. But we are planning to expand. We are planning to offer lung transplantation to more and more patients. But I think this study demonstrates that it's feasible and we can do this safely. So David spent a few minutes talking about when to refer, the medical indications to refer. And my plea is to supplement what he said from a surgical endpoint, to say that when you have an inpatient with end-stage lung disease, before they get debilitated, that is the time when you refer the patient, before they become so debilitated that they can't move. And if we're talking about post-COVID-19 or ECMO patient, as soon as you think it's unlikely that the patient will recover, and before debilitation, because it's very difficult to rehabilitate a patient who is on ECMO. It's very easy to bridge a patient on ECMO, but it's very difficult to rehabilitate. For somebody who's completely debilitated, to try to rehabilitate them while they're on ECMO. This is a video that was, we can lower the volume a little bit, that was done, I think, about 10 years ago when, and it was put on YouTube and also on UCLA website. Some of this is graphic, so I hope that you bear with me. This is a patient who had bronchiectasis and had a right lower lobectomy because of an infection, and was, I think, turned down at a couple of centers and was referred to UCLA, and we accepted it. And I think that we have some good visualizations, so I'm going to share with you.
And this is the inferior pulmonary vein.
This is the inferior and superior pulmonary vein. I don't know if you can.
So this is the aorta. This is the aortic cannula.
Yeah. So this is the head here. This is the aortic cannula. This is the venous cannula. This is obviously the heart, the left lung, and the right lung. And this is the donor lung being brought in. And this is basically how the lung arrives in the operating room, in a bag full of ice. And this is the way that the lung is delivered. It's actually inflated with the bronchus completely stapled. This is the edges of the pericardium that we usually cut out. And you look at here, and this is the back of the heart. This is the left atrium. You see the right side or the left pulmonary vein and the right pulmonary veins. And this is the aorta. Sorry, this is the pulmonary artery.
This is the trachea.
This is the trachea that has been stapled. This is what the donor lung or recipient lung with bronchiectasis looks like. Okay. That has been explanted.
And
now we're looking at the hilum on the left side. This is pulmonary artery, superior pulmonary vein, inferior pulmonary vein, and this is what the bronchus would look like when it has been cut. You can see the edge of the endotracheal tube in there. This is the new lung, obviously deflated and ready to be implanted. We start with the anastomosis of the bronchus, and you can see that this is the membranous part of the bronchus. This is the cartilaginous. Again, the patient's head is
the membranous portion has been completed
here.
And this is the left.
So this is the completed bronchial anastomosis here.
It's an end-to-end
this is the pulmonary artery. This is the left atrium.
Poropolline sutures.
We cover the bronchial anastomosis with additional tissue to increase the amount of vascularity. This is the pulmonary artery anastomosis that has been completed.
And this is the pulmonary vein
and
anastomosis.
this is inside of the left atrium. This is the suture line that you can see here.
This is the left side of the pulmonary
And this is
vein
open, that the anterior wall is going to be reapproximated.
Now he's completely on his own.
So now the patient is actually off pump. In other words, the patient is fully, the new lungs are working. You can see the monitor, obviously the vital signs, the PA pressure, and this is what the patient would look like after the procedure, before he or she is taken upstairs to the ICU. And this is what they would look like in a day or two after surgery, and then a few days before going home. And obviously this is where they all end up after about 10 days or so. Sure. A few words about the UCLA lung transplant program before I ask Dr. Gudzenko to come up. This is the volume of the UCLA lung transplant program. In 2020, we did 121. Last year, we did about 71 lung transplants. And these are some information about the outcomes. The median duration of mechanical ventilation after lung transplantation was 1 day. In other words, more than 75% of the patients were extubated within 24 hours after lung transplantation, which I think is a testament to the team again. The incidence of PGD3 at 72 hours was 5%. National average is anywhere between 10 to 30%. The median hospital stay was 14 days. The early incidence of stroke or major cardiac adverse event was less than 1%. And this is the early survival of the UCLA lung transplant program per year over the past 5 years, exceeding 97%. This is a report card of some of the lung transplant program in Southern California. This is the most recent one that was published by SRTR about a few months ago. And it compares the three biggest lung transplant program in Los Angeles. And I want to, and there are 4 stars are supposed to be good. And the first column is survival on the waiting list. The second one is getting the probability of getting transplanted. And then this is the 1-year survival. And you can see, as you can see, the 5-star or 5 bars are always good. And this is where UCLA was with the volume of 91 lung transplants. I think the success of this program is a reflection, obviously, a team effort, and a team that is partly reflected on this slide. I think that a lot of people who are here in the room are partly responsible for the success of the lung transplant program. And with that, I would like